And I want you guys all to know that I believe that the people in this room and the people in our community are really the chosen ones in dentistry. I think we're part of a big movement for actual holistic health and awareness. So thank you all for being here today. It's not easy, especially when it's your first meeting. It's very overwhelming. I was just talking to Dr. Sonda Moldovan yesterday. She brought me to my first holistic meeting. It was the IAOMT. And I was in the back talking to some other practitioner about what I do, and he literally made me cry. Because I'm an endodontist, as was said in my bio, and that doesn't always go over well in this group, but I'm here to change that. I went to my first IAOMT meeting, and I was greeted with a warm, friendly hug by this lovely man, Eric. He's left this earth recently into another realm to do some other good work, so we love him, and we thank him for everything he's done for the ozone community and the biological dental community. So I'm not going to talk about anything too controversial today. We're going to talk about root canal treatment prevention. Thought you guys would be excited for that. So how do you take these cases with deep caries, encroaching on the pulp, some of them look like they're right into the pulp, and prevent root canal treatments on these teeth? That's what I want to talk to you guys about today. I know it's really exciting. We all might have our protocols and have had success with this in the past, but I've really honed in on this, and this is one of our favorite things to do at my practice in Los Angeles. So when you see these cases come in, this young girl came in and she's like, Dr. Kanter, I do not want a root canal treatment. And obviously, when most people look at a situation like this, they feel like they might be destined for a root canal treatment or an extraction, depending on how you're guiding your patients. I told her I will do my best, no guarantees. But the question is, how does she get here? We've talked a lot about this, and I know it can almost feel confusing. Is oral hygiene even an issue when you have plaque buildup sitting on teeth? And unfortunately, we're not from these ancient communities where we're eating the best foods. Like, we all have processed foods in our diet, even when we try to avoid it. So I think, and I know, I'm a big advocate of excellent oral hygiene. Okay. But we have a lot of factors besides oral hygiene in the oralome and dysbiosis. We've got EMFs, we've got toxins everywhere. Junk food, things that are altering our DNA, and with epigenetics, sometimes turning things out for the worse. Most of us were taught in dental school that cavities start from acids being pooped out from bacteria. While that does cause enamel erosion, it doesn't actually degrade the dentin, I think, like we once thought. There's a systemic theory of caries. It's actually our own MMPs that are what break down the dentin. And this is happening because of a dysfunction in a hormonal flow. A healthy tooth is nourished by blood supply to the pulp. The dentin is nourished by a centrifugal outward fluid flow through the tubules. Now, when you're healthy, when you're not eating processed foods, refined sugars, you have minimal stress in your life, you're getting this beautiful outward flow, and it's helping recognize the microbiome in the area, reach a homeostasis there, and send information back and forth. But when you have increased sugar and stress in your diet, and they studied this in mice, they actually saw the fluid flow reverse, and that allowed more pathogenic bacteria to come in and allowed this destructive inflammatory autoimmune process called caries to happen deep into the dentin. So how do we get to this, the eubiosis in the oralome? Exercise, that Weston Price diet, antioxidants, great oral hygiene, all of the things, really clean water. We want to strengthen our terrain. How are some ways we can do that? Well, I was super stoked to see Morley here. I'm actually a new student in the RCP. So it was really exciting to hear him lecture and to drive some of these things home. I recommend downloading his book and also the RCP kind of summary, which is about 85 pages, and they offer it for free. They're here to help you learn how to help yourself, your family, and your patients. And just some of the simple starts are adding trace mineral drops to your water, whole food vitamin C, cod liver oil, bee pollen, beef liver, boron, iodine, and magnesium throughout the day in different amounts and different times. So you guys can dive into that for yourself and your patients, and I highly recommend the course. Of course, we have the Weston A. Price diet, which we talked about this morning. I personally take the beef liver pills. We've got our omega-3 fatty acids. This is a really cool study that I've talked about in the past, but it's just so amazing. They fed mice omega-3s for a month, and then they had another group where they didn't get any of these nutrients. They exposed the pulps, added a bunch of bacteria in, and then they waited to see what happened. And the mice that had the omegas did not develop inflammation. They did not develop apical periodontitis, and their systemic inflammation was down as well, totally normal. The mice that didn't have the omegas had increased systemic inflammation and apical periodontitis formed. So what does this tell us? We like fish oils. This study was specifically looking at high-dose EPA. We also love antioxidants. So green tea extract, and this is the BCQ supplement is one of the top supplements in our practice. I give it to every single patient. They actually ran out of it, and I think that's because of me. It's got bromelain, curcumin, boswellia, and quercetin, and we recommend very high doses during their dental treatment protocol. So as a general dentist, you guys have an opportunity to get your patients on this right away before you start your treatment plan. EPA, cod liver oil, BCQ, these are all really amazing things to help decrease inflammation. So then when you start removing caries, even if it's not deep, you're going to decrease the inflammatory response in the body. Curcumin is amazing at reducing C-reactive protein, IL-6, TNF-alpha, IL-1 beta, and increasing IL-10. I think there's a typo on that one. And then self-care. We've got exercise, clean water, getting in your saunas, doing all the things. And oral hygiene is top, in my opinion. I'm actually creating some educational content, and I tried to get these models to like brush properly, and I was there coaching them through, and we did all the video shoots, and I was like, I'm just gonna have to do this myself, you guys. Because I don't know about you, but no one knows how to brush their teeth. My patients, at least. And I see a lot of patients. I'm endo, so I see a lot of new people flowing through, and I actually stop and I ask them, I say, hey, show me how you brush. And no one knows what they're doing. So I take the time to show them on a model, and every one of them looks at me and says, wow, I've been doing this wrong for 50 years. I said, okay, well, we're gonna help that. And I actually have a toothpaste that I'm gonna be launching this year I'm very excited about. I'm not gonna go into too much detail, but there's gonna be two types. One's gonna have CBD and ozone, and the other one is more of just a simple everyday one with just all natural minerals and things. So more information on that, and the QR code's there if you guys wanna learn more, sign up for release info. CBD's really, really cool. CB receptors may be helping in the dental pulp for sensory transduction, biomineralization, and tissue repair. So I know this is an anti-inflammatory agent that we can easily add to toothpaste, especially now it's becoming more and more popular and legal, and so I'm excited to be able to offer that in the toothpaste. There's some studies that show that cannabinoids are substantially effective in reducing colony counts of bacteria, almost equal to things like Oral-B and Colgate in the mainstream. And I don't just tell my patients to brush, I have them use water flossers and all the things. And obviously when they're coming in and you're doing these heavy-duty ozone treatments, you want to repopulate the mouth with the right bacteria. So whether that's prebiotic and probiotic foods, or some people really love and have great results from probiotic mints. This is a company called Orasana. Dr. Sanda Moldovan developed this product line. It's an incredible water flosser and all these different products, and I think even like ozonated water bottles and things like that, some of my patients are coming in that see her too. So really exciting product line if you guys want a good resource for that. So let's drop into integrative dental care and regenerative endodontics. So here's my little diagrams of kind of the three main ones that you guys might find in your office as treatments to provide. Indirect pulp caps, direct pulp caps, and pulpotomies. I think we all know what those are essentially. But regenerative endo is defined as biologically based procedures designed to physiologically replace damaged tooth structures, inducing dentin, root structures, as well as cells of the pulp-dentin complex. Patients love this. They love anything that says regenerative in front of it, and we're doing this every day, and you guys can do it as well. So indirect pulp capping, this is the most conservative form of vital pulp therapy. We're avoiding direct pulp exposure. We're decreasing the risk of pulp exposure to bacteria during the procedure. When can we do it? When decay can be removed without exposing the pulp. And what is the treatment? It's a combo treatment of laser, ozone, and bioceramics. This one's out of frame a little bit, apologize. This is direct pulp capping. The main difference is you have an exposure during caries removal. That is usually, we hope, is a mechanical exposure and not just a full-on caries exposure, because then you know what direction that usually ends up in. But the health of the pulp is verified visually, ideally under a microscope. So if you guys are doing these procedures, if you're using lasers, I highly recommend you have really great magnification. It has to be at least 4.5. You really need to see the tissue interaction of these procedures, and you need to be able to see, is this pulp, is it oozing? Is there any purulence coming out? Like, what am I looking at? And so I'll show you guys some photos and some videos here as we move forward in the presentation. You want to make sure you can control the bleeding, of course, and you need to be able to place the capping material so it's well sealed. And I know you guys are all using dental dams on these cases, so we don't even really have to get into that probably. Why do we need to keep our teeth alive? Well, we don't want to do a root canal treatment. And we know that teeth are vital components of this complex neural network that sustain our life. We all love eating. We don't want to break our teeth. Perfect. Thank God for these pulps that give us a lot of information. Occlusal forces cause stress in our teeth, and that activates our jaw-releasing muscles. So whenever we bite on something too hard, we know immediately to open it. Somehow we have, sometimes we have interfering information and people end up cracking their teeth because of all of the malocclusions and all the things that you guys have heard about a little bit this weekend. So preventing these from happening is early intervention. So this is a classic case of endoslaze. This is the protocol that I do using laser and ozone and endodontic treatments. But usually if you would look at a case like this and then you see how deep the caries is and close to the pulp, I think it's pretty amazing that we got this result on the right. You guys have pretty straight faces, but can I get like a little excitement here? Okay. I mean, you would be stoked if you got that result in your practice, yeah? So how do we get this? How do we get there? Number one, we offer our patients emotional body support. We use a thing called the MEND device. It's frequency-specific microcurrent. There's different companies. This is the one that I use because the trainer is absolutely amazing. She can come out to your office if you pay her enough and train your whole staff. But we use this to calm the entire nervous system and to help clear traumatic memories from the fascia that are connected through the whole body and specifically to this tooth that we're working on, which usually has already had a lot of trauma. They have these emotional experiences from previous root canal treatments where it was just horrible, and we want to clear those. And so by running these emotional concussion protocols and physical concussion protocols, where our patients leave and they're like glowing, they're so happy, and they're just like, I just had a root canal treatment, why do I feel so good? And I attribute a lot of that to this microcurrent technology. I do hold courses on this usually once a year with my trainer. And so if you guys are interested, my email will be up at the end and you can reach out and I'm happy to include you in that. They've actually done a lot of research on this technology and it's super cool. They took blood in real time. So they hooked someone up to the machine, took blood, started looking at inflammatory markers, and every 30 minutes they started testing it. And what they saw was that these numbers were dropping. Substance P from 180 down to 54. IL-1, 330 down to 80. IL-6, 239 down to 76. Just with frequencies running through the body. The specific frequency that was running was 4010, if for those of you who know. It's inflammation in the spinal cord. This technology also increases ATP production up to 500%, protein synthesis, signal transduction. It's really magical. We use it on every single patient, every single case, no matter what they're doing. We also support our patients immediately with supplementation. So it's part of our email that goes out when a patient makes an appointment. We recommend they buy this right away. We use an account on FullScript, and so we get a little kickback from that, and the patients are happy because I give them a discount. And so BCQ and EPA are going to all of our patients. I was looking for a study that talked about these specific elements with the teeth or pulpitis, but what I found was this other paper, and I just thought I'd throw this in because I thought this was kind of cool, and I don't even know how to say this word, so I'm going to do my best. Erythromelalgia is a rare neurovascular syndrome characterized by erythema, heat, tingling, burning in extremities, which may be aggravated by exercise stress and increased ambient air temperatures. I was like, well, that sounds like a pulpitis to me if I've ever heard one. And so they did this case study and they gave this patient this. She had tried other things like topical lidocaine and everything for this pain. Nothing worked. She started taking the BCQ and the fish oils in combination, almost just how I recommend it. And all her symptoms went away and her mood got better. Step 3 is diagnosis and treatment planning. You need to know, are these patients in severe pain? Is this a hot tooth? Are you not even able to numb the tooth? These are cases that are probably not great candidates for vital pulp therapy. We know when we can look at the histobacteriology of these deep caries, we've got tons of bacteria in the tubules, so it's like, how are we going to deal with that? And every person's different. We don't know if it's, to the point where they're starting to get these major effectors of inflammation, like the histamine and like the swollen blood vessels, all the cytokines. We don't know where our patient's at, even based on clinical testing. It's really a hard judgment call to make. So you guys will get better and better at knowing which cases are gonna work. And I just recommend you never give any guarantees. So, hey, we're gonna do our best to save your tooth. And I just straight up tell them, I said, it's either gonna feel amazing tomorrow or you're gonna be calling me, begging me to do a root canal treatment or take your tooth out. I was like, or it might feel fine for a while and then it might hurt later on, or you may never notice a problem, but your tooth could still die. So it's like really going over all the possibilities that could happen so they're educated and they understand and they usually are like, let's save this tooth. So let's talk about the steps of endolays. Number 1 is isolation. Very important, please do it. Build up your proximal walls if you have deep caries to block out any bleeding tissue. You're gonna use well-sealed blockout agents, have a matrix, have a dental dam, Optrogate, even sometimes a gingivectomy is necessary if you've got bleeding tissue nearby. Don't know if this video is gonna work, let's see. Yep. So this is the ND-YAG. It's the side laser on the Photona Lightwalker that I use. It's very similar to effect of a diode that you guys might see. Causes a little more inflammation in the tissues post-operatively, but it's great for hemostasis. So anytime I have tissue close to the area I'm about to start doing deep caries removal, I'm clearing it out and I'm getting really good isolation. Sometimes we'll build up a wall, like this one, IRM was built up beforehand, so I was able to actually just go in and access, but leave that wall intact. You don't want saliva coming into your zone. I don't want saliva on the dentin, straight up. What's gonna happen with saliva? It's gonna contaminate the prep and it's gonna interfere with your bonding, but also there was a study that looked at even sterile saliva induces IL-6 and IL-8. Anything on the pulp is going to create an inflammatory reaction. Anything on the dentin is going to create an inflammatory reaction. So keep it clean all the time. All right, so we've got isolation. And then once you're in there, you're going to do your normal prep, enamel, outline form. Get all the enamel cleaned first. You don't want to go right in for the pulp and then you still have like enamel caries to remove. It's silly. So remove everything circumferentially around the outside. Layer by layer, you start getting deeper, closer to the pulp, so you can kind of sterilize as you go. So first enamel, then you're gonna do your outer dentin, which I call D1. You're gonna do all that with the high-speed handpiece. I usually do that unless a patient really wants like a full laser experience. I tell them no problem, might just take a little bit longer, but I'm happy to do that. Then once you get into the deeper areas, you're going to use laser. And if you don't have a laser, I get it. You probably will at some point in the future, maybe immediately after this lecture. But if you don't have it, you can use a spoon, and your ozone is going to be hypercritical. So we'll talk about that. And these are as you're getting into the D2, D3. That means really deep. We're getting close to the pulp. So I guarantee if you take a slow speed to this tooth, like you are probably going to have a pulp exposure. So don't go straight in with that, please. Also, really keep in mind what's happening when you're using a slow speed and a burr. You're just kind of reaming through this really contaminated dentin, and then maybe you're giving a quick wipe to the burr. I don't know. I mean, maybe not. So if I were you, what I recommend is having a series of sterile burrs. D1, take care of it. Now you're a little deeper. Okay, I'm going to get rid of that burr. Don't touch it with your dirty gloves. Use your cotton pliers. Put it in. D2, D2 and a half, D3. Really think like an endodontist when you guys are trying to do vital pulp therapy. We are OCD. Okay, we're not letting bacteria into our zone. You can use spoons, you can use these micro spoons. Mark Kalana, my laser mentor, he's amazing and he developed this. The company is called American Eagle. You can get them from different companies. They're teeny tiny micro spoons, so they're nice to get like some of these last areas. But I think it's happened to probably any restorative dentist in here. You go in with the spoon in that last layer and you just lift the whole roof of the pulp chamber up. I know it's happened to you, it's happened to me. How do we prevent that? Laser and ozone is very helpful. If you don't have laser, ozone, and I'll show you guys what that looks like shortly. This is what the laser looks like. So I'm just quickly moving it around the whole area, and this takes time. We charge a lot for this procedure. Okay, this isn't like an insurance-based pulp cap. Like there's a lot of fees because it takes a lot of time, almost as much as doing a root canal treatment in our practice. Why do we use the laser in these areas? Because it's actually completely annihilating the bacteria and it's removing smear layer. It's like a win-win. I'm not touching the surface, I'm not interfering. It's literally light, energy, and water just cleaning the surface. And they've done studies where they look at PCR analysis, and after you treat the dentin with the laser and remove all the decay, there's no bacteria remaining. Let's just talk very briefly about lasers so you guys know what I'm talking about, because not all lasers are the same. There's a bunch of different ones. And when you look at them, you're talking about what wavelength are we dealing with. I'm using an erbium class of laser. There's two erbium classes. There's erbium YAG and erbium YSGG. Photona is erbium YAG. BioLase is erbium YSGG. They're great for this type of decay removal. Each of them have perks and drawbacks a little bit, but they're both great. This is what's inside. What the hell does erbium YAG mean? It means that there's a crystal of erbium, yttrium, aluminum, and garnet inside this box, and then they put energy through and a certain wavelength of light comes up. That light happens to really love water, loves it so much it makes it explode, and that's how we treat these teeth. So it's a combination of affecting the water that's actually inside the dentin, because there's a high water content in dentin, and it's also, there's a triangulation of water coming out of the handpiece that's perfectly hit right where the light's hitting, and so you get a little explosion. So it's called ablation. You're ablating the tooth structure, and it's going to be a lot easier to ablate decayed, soft, gooey, high water content structure than harder dentin. This is a video. If anyone knows Dr. Kalana, you've probably seen this. It's such a good video that shows the power of lasers. This is a case done without any anesthesia. You'll see the tooth structure just seems to disappear. It's just such a good video that highlights how amazing this is to remove decay without creating any contaminants or irritation in the underlying dentin. Mark is the expert in all things laser, and if you have a laser and you don't know how to use it, I don't care what kind of laser it is, he is available for in-office training, and I would highly recommend it. I basically was just stapled to his hip for a few years as I learned everything that I possibly could. So what's important when you're working above the pulp tissue is there's a certain way you can handle the laser, and it's called defocusing. So you don't want to have the laser right up over the pulp tissue and you don't really know what's going to happen. You start back, it's called defocusing, and you let the laser light slowly start to interact with the tissues. How do you know what's happening? You're looking through a microscope and you can actually see what's happening. So we're going to use a defocus beam when we're on these deep areas. This is what a laser looks like just working on composite. This is another video from Dr. Kalana that he shared. If you move it really fast, the penetration is very shallow. That's what I want to do over the pulp. If you move it really slow and succinct, then you can see it's going to penetrate deeper. Okay, so when you're working on the pulp, you want to move it quicker and defocus. Those are the two things to take home for those of you new laser users. What we want to do is we want to prevent breaking through the tertiary dentin. So this tertiary dentin is like under the caries, and our bodies are really brilliant because it's not like the normal parallel tubules, which is just like, come on in, everybody. It's like open. The tertiary dentin creates like all these weird shapes and structures, so it helps block the bacteria out to buy us more time to get in there. Okay, but these deep areas in tertiary dentin are actually free of bacteria. So if we can have an aseptic technique and we do this carefully, we can avoid exposure in a lot of cases. So now we're down to step 5 and 6, ozone prep, insufflation, and then repeat. There's going to be a slide at the end that has the full list, so you might want to wait to take pictures. Okay, so if you're using ozone and you're filling up a syringe for your restorative materials, I need you to rethink what you're doing. How fast does that syringe fill up when you're on the machine? Like 2 seconds, 3 seconds? I highly recommend getting the handpiece with the tubing and you have continuous flow. Sometimes I'm working on this for 1 to 10 minutes in a case. How many handpieces are you guys gonna, or how many of the syringes are you guys gonna fill up? It's crazy. Don't do it. You need to order the handpiece. Promo Life's here. Go over afterwards. I'm not getting paid by these guys. None of them. Just go over here, get a handpiece, get the tubing. It's really nice if you have the foot pedal, because if you don't have the foot pedal, it's like when you're ready, you turn it on, and then it's like ozone's coming out. It's like, okay, is all the suction in position? And it's like this whole thing, and I'm always breathing too much ozone. I've got a few longevity machines and one Promo Life, and I need to get the foot pedal. I think they have one, but our machine might not take it. So get the machine that can take the foot pedal. That way you can just activate it when you're ready. You guys are in complete control. All right, so you want to clean out all the bacteria because you're going to get better bonding. That's a no-brainer. Here's the full step. So now we're going to go through the pulp stuff, which is exciting. We'll have that slide up again, don't worry, and I'll keep it up for a second. So we're in our deep area. We're using the erbium laser. We're using the ozone gas. We're repeating as many times as we need. You guys will see a video of it. You're placing your BC sealer. So I'm working with a company called Brasseler. They may or may not be supporting me today, I'm not sure, but I just wanted to let you guys know about it. I highly recommend their product. It's called BC Sealer. They've got a few different forms of it. There's like a high flow sealer, very liquidy. I wouldn't recommend that for this. There's the regular sealer, you can get that. It's got blue writing on the thing. Then there's also root repair material injectable, which is a thick liquid. And then there's a putty. So they have a whole line. It's all calcium silicate, zirconia oxide. Amazing product. And it's easy to use. So MTA, I don't love it. It has aluminum. It's also very difficult to use. So I've completely transitioned to this. They have a patent on their calcium silicate formula. When it comes in contact with water in the dentin, it lays down a layer of hydroxyapatite. No one else is doing this. Everyone else has resin in their bioceramics. So if you're using another brand, just check the MSDS, talk to the rep. Most of them have resin. So that's going to create more inflammation. We're going to start small. This is just an indirect pulp cap. Not quite as great as Dr. Kalana's video, but I'm trying. You can see I'm using the Optragate to hold the soft tissues out of the way. First, I'm doing the outer. Now I'm going in and moving quickly over the deeper areas of decay. Now we're even closer. Always cleaning the outside and working your way into where you think the pulp is. Now I'm going to make sure I'm not having any sulcular fluid coming into my area when I start to do the next step. So I pack a little cord there. You can see in this case I also did a little gingivectomy to move some of the tissue out of the way. If you can see the texture on the tissue, that's what's great about the laser. That right there, what you just saw was a little microsuction. So I highly recommend that. You don't want to blast air at these areas. So you put a composite tip on a surgical suction and go in and just gently pull out the moisture. Because when you put the BC sealer down, if there's too much moisture, it will just kind of disperse. You want to keep it in one area. So you don't want it to be desiccated. I wouldn't recommend blasting air, especially if you have a full pulp exposure. The microsuction works really great. So you place the sealer right over the area. What are we using? We're using these biocompatible materials that I'm mentioning, BC sealer, silica-based cements. They've got amazing remineralization capabilities. So dentin just starts growing. So the pulp will shrink and lay new layers of dentin down. They work really well in all aspects of endo. I use it for root canal treatments. We use it for apicos. It significantly improves the healing of the pulp. What are you looking for in your biocompatible materials? Number one, you want it to be easy to use. You guys want to use it. These come in a pre-mixed injectable syringe. You can't go wrong. It's antibacterial, so that's another great thing. And then also it's forming this layer of hydroxyapatite, which is amazing. When you put these things down, we're seeing an absence of inflammatory reactions in the host tissue. This is a study that actually treated teeth. They did root canal treatments, they did apicos. They were teeth that were going to come out, as you can see, for perio reasons, and they treated it and then histologically looked at everything and saw there's no inflammation around these materials. So it helps with wound healing and regeneration of bone and cement and dentin. So over top of the sealer, we can't bond to that, so we have to place a liner. I use this donut technique. I first outline it so I'm in contact with dentin and the sealer. If you try to cover the whole thing in one fell swoop, it's like sometimes it starts to mix together and then the whole thing will end up lifting and blowing off. So I'll show you guys multiple videos and animations that I made, but you create a donut around it first, light cure, just a flash cure, then you cover the center portion. And these are some of our recalls: clear sinus, deep fillings, PDLs are looking good, teeth are vital. And we have other things that we can do after we place these restorations before we just send them away. We have treatments called vitality support. I do these on teeth that if they've already been restored by a dentist and they're coming to me with like reversible pulpitis, we don't want to just go in and start drilling or working on a tooth again. So I'll do these vitality support treatments without any actual, vital pulp therapy procedures. And we also do it adjunctively with the vital pulp therapy procedures. So what is it? We already talked about the terrain, diet and supplementation. We talked to our patients about that. Low-level laser treatment, photobiomodulation. It's really important. You want to keep it to 100 joules per centimeter spot size. If you don't know what that means, just come talk to me about it, but you want to make sure that you're monitoring how much energy you're putting in, because if you put too little, you're not doing anything, and if you put too much, you're going to inhibit the healing. So there's a really kind of honed in amount of energy you want to put. Then we do PDL injections. How many people have the wand? STA? Okay, you're lucky, because you're going to be able to do all this. It's really cool. Of course, you can use other PDL injections and you can infiltrate all you want, but I think that injecting the PDL of the tooth in question is probably one of the best ways we can get some of these things in there. Neural therapy, peptide therapy, homeopathics, and then of course low-dose ozone injections of the area. I use the Genova handpiece. Now they have the Marco handpiece from Fotona. It's very similar. Hold it over the apex, hold it over the IAN area. I just sped this video up, but basically 100 joules, watch your counter. It's depending on how much energy you're putting in, it's anywhere from 20 seconds to a minute per spot size. What is low-level laser treatment? Well, It's actually light going in and activating your cell membranes, your mitochondrial membranes to do really good things, increases ATP production, increases collagen formation, decreases inflammation, all of the amazing things that ozone does. It's very similar, just different mechanisms. Also, neural therapy. So neural therapy is the use of procaine to inject in any sort of scar, lymphatic area, peripheral nerves, all of this. So you can use this in dentistry in certain ways. One of the ways you could do is actually activating the lymphatics. I do this all the time with a submandibular injection of procaine followed by ozone. This gets things moving and flowing. Because we get blockages here, you can do the best work ever, but there's a blockage in energetics and lymph. You may not get the healing response that you want. Of course, we have the supportive treatments with the single tooth anesthesia. That's called the wand, STA. So what we do is we actually put our cocktail, whether it's homeopathics or peptides, I put it back in an empty and cleaned anesthetic syringe, put it in the wand, and drop by drop, it is giving the solution into the PDL of this tooth. It's a really nice, gentle way to introduce these agents to the area. When I use homeopathics, I use isotonic ketone, I use procaine, and then Trameal, lymphomyosat. Those are the main ones that we make in the homeopathic cocktail. You can inject those infiltration, IAN, PSA, depends on what you're doing. You know, if it's a whole zone or a sinus, you're gonna inject differently than if it's a single tooth that you're trying to reverse a pulpitis. As far as peptides go, we just incorporated using those as well. So we use BPC 157. It's gonna be amazing for angiogenesis and expression of a lot of growth factors that are gonna enhance healing. And then also thymosin beta 4, for oral inflammation, and this is going to help with healing, inflammation, regeneration, all the things. You can use them. You can use these two in combination, or you can use them separately. So here's everything we need to do it, and we put it back into the anesthetic syringe. So our dose is 2 milligrams, and these are all the things that we need. Okay, I'll leave this one up if you want to take the picture of the full protocol. Okay. And this is just a quick, photos of the process. Some of the things are missing here. I didn't get all of the photos, but it's the idea, so we'll go through now. So again, proper isolation is critical. If you have an exposure and you already had your isolation, you're so happy because you don't have to worry about blood and saliva. You can use the slow speed handpiece in this case if you still have decay, just don't use it on the pulpal floor. Like here, I'm using it on the box. This is my high-tech animation. Staying away from anywhere near the pulp. Then I'm gonna use the laser, and at first, once I have the exposure, I'm not gonna keep hitting the exposure with the laser, but I still have areas to clean. So I'm gonna laser everywhere around the exposure, but not right over the actual exposure itself. Okay? Then we're gonna go back and forth with that and the ozone as many times as we need. So the ozone, this is a little series of stills, I think. So you're literally holding it in place for a long time. It takes a couple minutes. The whole area should turn into like this beautiful crystalline look, white, frosty dentin. And it takes a little while to do that. So make sure it's coming out, hold it for as long as you need. And when I'm using this, I'm actually using it as a spoon, which you'll see in our video that's coming up shortly, how I'm actually using the ozone to remove the affected dentin. Then once everything's pretty much ready, I'm still going to actually laser over the exposure because I want to make sure that area is sterile. So there's different settings for this. We are going to be hosting courses quarterly, teaching you guys how to use your laser, teaching you how to do this hands-on with a lot of live cases. So I know it seems easy when you're looking at a diagram and it's a lot harder, but you have to change your settings according to what you're doing. And so you really need to understand your laser settings. Once we do that and we have the exposure, I started doing this, which I think is really amazing. Insufflation with ozone of the isotonic minerals through a cotton pellet over the exposure. I'm very proud of this. I love it. I'm excited. I think it's probably just driving these amazing minerals that are part of our, our existence into the pulp. These are sterilized deep sea minerals from like the best areas that have all of the nutrients that we need. So we started doing that. Then we add liquid PRF over the exposure. So as soon as I know there's going to be an exposure, we call the nurse in, she draws the blood, or I'll do it. I have certain team members that can do it. I do it myself sometimes. We draw blood, we do the spin. It's only 5 minutes. So while I'm doing the isotonic bubbling, I'm spinning my PRF. Then we drop it in and I just let it soak for like 5 minutes. We're going to talk about this a little more, but I basically did studies with PRF on dentin pulp stem cells, which I'll talk about next, and did a lot of cool things. But what I didn't even realize is like this is helping with coagulation here. Like this is helping actually form the fibrin clot because there's all these platelets. I was like, this is amazing. It's a win-win-win-win. So if you have a PRF machine and you even think you might have an exposure, you tell your patients, hey, we can draw your blood, use your own growth factors to increase the possibility that this thing's going to work. And they are like, it's a yes. I've never had anyone say no. These are your settings, 300 RCF, 5 minutes. We just let it soak. So the studies that were done looked at dental pulp stem cells in contact with liquid PRF versus PRP. And we looked at the proliferation of the pulp stem cells after being in contact with the PRF. The PRF was superior, not by much, but it was superior to PRP. And we looked at mineralization. It was quite better at mineralization, so the pulp was able to form mineral structure like dentin. And then what was really cool is we did it in the presence of LPS. And when you looked at LPS next to the dentin pulp stem cells and you looked at mineralization and all that, the pulp stem cells did not do well if there was just LPS in the mix. But when you added PRF and LPS, which we know LPS is there, this is endotoxin. This is part of the bad bacteria that are down in these deep caries. So you're gonna have LPS for sure. And the PRF actually offset all of the negatives that LPS was putting on the pulp. So it was amazing. So what are our conclusions from this study? IPRF significantly balanced the negative effects of LPS, showing that not only reverted the mineralization level to normal, but also rescued the gene expression of the odontoblastic markers. I did this study with Dr. Rick Myron. If you don't have a PRF machine, I highly recommend you get one, whether you're doing vital pulp therapy or extractions. He holds courses literally all the time. His company is called PRF EDU, and I highly recommend his courses. So now we have our exposure, we did our PRF, we used our microsuction to rinse off the excess. Now we're gonna put our BC sealer down, and now here's the donut liner. So I'm gonna do the outer portion, which you see in yellow, and then the inner portion I'm gonna fill in after. So now I'm gonna show you guys a video of this whole process so you guys can watch and I don't have to talk for a second. I guess I have to talk a little bit. So this is the ozone. This is Carrie's detector. So I'm seeing where am I at. But the ozone, just using a ton of it. The gas is coming and I'm using it as a spoon. This is obviously really sped up this video. But we just keep ozonating, keep ozonating, keep ozonating until it's getting drier. The decay is dehydrating, and I know I'm eliminating the bacteria that are present there. Then I'm going to go back and forth with the laser, with the ozone, laser, ozone, laser, ozone. I didn't show the whole actual treatment because it would be too long, but you guys get the idea. Now, when you're doing this, you're creating a lot of smear layer. There's a lot of debris with that tip, just like a spoon would leave. You always want the last thing in contact with the dentin is the laser light. You can do ozone gas without touching the surface, but I highly recommend just the last thing should be the laser. If you don't have a laser, you could use like an EDTA, like we use in endo, an EDTA with maybe a micro brush or let it soak, and you can just scrub it because that will help remove some of that smear layer. Or you guys have your sandblasters and everything, but you have to be careful with the pulp exposure, of course. So I highly recommend the laser. I'm using my microsuction, placing the BC sealer. The PRF was in there. I don't know if you guys caught it, but it was like soaking for a second. Filling in the donut, cure. Now I'm gonna do immediate dentin sealing. So my floor is clean from the laser. So after I get my pulp cap over, I'm going right to prime bond and doing an Admira X-Base, which is the Ormisur. So there's no resin. Admira is an amazing product, and they have a flowable that's really strong called X-Base. So I put that on the floor. Then I'm not concerned with contamination at this point. So I take the dam off, and I have my assistant place the matrix, and we get that nice and sealed, and then I do the rest of the buildup. If I know that I'm sending it back to my referring dentist for an onlay or a crown, I would just place a temporary over my protective restoration. But my protective restoration is well sealed. It's covering the entire dentin floor, and I'm very happy about it. These are a couple of cases. So like in the courses that we host at my office, this is one of them. And I actually did this case live in front of everyone. I started with the lower one. He just came in to see me. This guy was extremely, you might not think it, but he was extremely healthy. He didn't eat any sugars or anything. These areas of decay had been there for 10 years. They were vital. He had no symptoms. He came to see me and said, Val, he delivers my Alive water. So the Alive water is like amazing Oregon spring water. And he delivered it. And he finally came in and said, Val, will you look at these teeth? I trust you. And I was like, sir, you need root canal treatments. And he's like, I don't think so. And I was like, okay, well, let's see. And so we removed the decay. I had an exposure. This was one of the early ones I did. I placed the PRF, did the restoration. Then I did the upper tooth in my live course, which was fun. Oh, by the way, no anesthesia, this guy. It was on that level, okay. So he's a freak. But these are when we finished, okay? And then he had, I believe he had crowns and everything placed. This is the 1-year recall on a CT. Now, I don't know if, I didn't have the PA, you guys, of the pre-op on 19. There was a huge widened PDL on the PA. That's why I was like, I should have put it up here, I apologize. I was like, you need a root canal treatment. He's like, I don't think so. This is a CT slice. That PDL is looking good. It was huge in the PA, which means there was a lesion there, and that was able to restore and regenerate itself with this treatment. And this is a 1-year, a 3-year recall. He just came in recently. I was like, Ara, we need a picture. Unfortunately, the assistant didn't get the message that I needed the lower two, but it's fine. We tested everything. They're vital. And then you can see the upper one. So everything's looking good. So how do we do these and then support them? I always get that question. How do you support the patients afterwards? You can do ozone injections at your recalls, at your hygiene appointments. I recommend as much as possible. If they're willing to come once a month, great. You can sell a package of 10 ozone injections for RCT support, or vital pulp therapy support. I usually would just do 1 to 2 cc's at around 15 micrograms per milliliter via infiltration, IAN, PSA, depending on how many teeth I'm trying to treat and what's going on. I also do low-level laser treatment at all the recalls. We can do the vitality support. There's charges for that. I usually will do the laser for free at their recalls. We do 1 complimentary recall, 1 complimentary CT. After that, we start charging like half price usually for CT images for follow-up, and we'll do like packages for lasers and all that. The vitality support injections, you could do homeopathics or peptides depending on what the patient wants. And then you have I do limited CTs for sure at the 6-month or 1-year mark to make sure everything's healed. There's no sign of infection in the periodontal ligament or bone. And then after that, I would recommend these teeth are scanned every 3 to 5 years. That's my recommendation. If patients have an issue with that, then we can decide other avenues. And then now I'm learning this weekend about testing the sulcular fluid, which I'm very excited about. Testing for these MMPs, because I have patients ask, especially after root canal treatments, mainly not as much vital pulp therapy, but they're like, how do we know? How do we know that it's okay? And I was like, well, I have a CT that shows you a healthy PDL, and I can drill back in and take a look. Those are my options, because I don't know. And, every time I go in, I would say our success of things looking really good is probably 98, 99% success when I go back in cases that I've done. I've seen one or two where like the sealer that I place on root canal treatments didn't set all the way. And so now I'm actually leaving a lot more moisture in the teeth. So that's a whole root canal treatment protocol that you guys probably don't want to hear about. But if you do, you know where to find me. So who are candidates for vital pulp therapy? Well, we don't really know, like we can't see the histology in each tooth, but we would like it to be, really mild, but there's not really a specific clinical test. I mean, we can do our cold test. We want them to feel it. We want it to go away relatively quickly. You need to compare it to an adjacent or, opposing tooth, something away that doesn't have a problem. And then percussion testing is also important. Here's another case. Is this a candidate for RCT prevention? This is a much older gentleman. He's got a crown that's leaking. I said, we're going to have to take the crown off. This is what it looked like. This is what it looked like. This is what it looked like. This is not a candidate for vital pulp therapy. It's necrotic or really close to being completely necrotic. So again, you don't never make promises. You don't know. I always treatment plan. This is the minimal we'll do today, which is our indirect pulp cap. Then we've got our middle, which is our direct with PRF. And then we have a full root canal treatment. Or I know beforehand if a root canal treatment is not in their realm of possibilities for them, then extraction. So this is a very important decision that you as the clinician has to make in real time. And I highly recommend using a microscope. If the visible pulp tissue does not appear healthy, if it's bleeding and you can't get it to clot, these are signs that a vital pulp therapy is not going to likely work. So when you see this and you're really hoping it's going to have vital tissue, and then this is what you see when you have the exposure, it's turning into this, okay? So that's everything. This is information on my educational website, which right now just has some basic stuff that we're offering. This is a way to email me. And I'm not going to be here for the panel, so I'm more than happy to take questions for the next 5 minutes, and then I can stay longer during this break period off the microphone. I didn't prep the technical team about that, sorry, so they might have to bring the microphone down.
I'll come to you with the microphone. I just want to give you the AGD completion code before we do the Q&A. RCT 32324 VK as in Val Kanter. RCT 32324 VK. And does anybody have a question for Val?
Okay, so you're using like Admira Fusion to build that, right? Which is that what I heard?
PRF liquid?
No, to build the tooth up, you use Admira Fusion, which is yes. How about biodentin?
I think that's probably a very great option.
Oh, okay.
Yeah, okay. I think that's fine.
And then the PRF for how long?
5 minutes.
5 minutes. And I wrote a question that it was too fast. Name of export of laser. I don't even know.
The name of, Mark Colonna, Collonna.
Mark?
Colonna, Collonna. And I think that if you just go to the Fotona booth, they can probably give you his information. You're welcome.
I've got one over here. Here.
Oh, hi.
Hi. The PRF, so you're placing that, you'll leave it for 5 minutes, remove it, and then are you leaving the moisture because that's got some goodies in it? Are you that's the last thing you do, then you'll lightly air dry and then place your BC sealer, or you ozonate a layer of ozonated water. What do you do after the PRF?
You could use ozonated water to rinse, but generally what I do is I take my microsuction and I just I circle around the pulp exposure. So I want to leave it on the pulp. And then I just actually suction the excess off of the internal dentin. Yeah, that's usually what I do. And then I've kind of gone back and forth. So sometimes I will rinse it with ozonated water afterwards. Sometimes I don't. I just leave it. I don't know if it's a make or break either way.
Yeah, because I mean, from a sterile standpoint, it's sterile, but you've got proteins and things that potentially could contaminate the ideal seal.
Yeah.
So, okay, so you will rinse it with ozone water and then lightly.
Yeah, just use
dry.
the microsuction to whatever fluid is there, whether it's the isotonic saline, ozonated water, the PRF, just suction it off so that way it's relatively dry when you place the bioceramic.
All right, awesome, thanks.
You're welcome.
That was my question too, was moisture. I mean, I feel like I saw a fair amount of moisture.
You want moisture with the bioceramic. It's hydrophilic. So when it touches these products, it's laying that layer of hydroxy apatite down. So you don't want it to be too dry.
And then when you put the sealer on top
And
of
then
that.
and then I suction as much as possible, like around the edges. So because the lining agent needs to be relatively dry.
How long do you wait before you put that on?
I put it on immediately.
Oh, wow.
Yeah, I don't wait at all.
It doesn't need to like set or anything like that.
It doesn't, well, it takes 4 hours to set. So I place it, and that's why that's the only reason I use the liner, is because it's light cure, and it works over the BC sealer.
Sure.
So the liners were designed, they're like calcium hydroxide-based liners that were designed to be light cure. You don't need to bond. And so a lot of people might use those as pulp capping materials,
Sure.
but I just layer it on top of the sealer.
Can I
Yeah.
ask 2 more questions? Okay, the carrier's indicator dye, what color was that?
It was green. It's ultra dense, dark
Okay.
green, but there are methylene blue and all those work really well.
Okay, cool. And then the Admira, say there's no resin in it, and there's inflammation that caused from resin-based.
So from what I understand, Admira is a pure Ormesur ceramic.
Sure.
Yeah.
And I don't, in this community, because I'm kind of new to it,
Mm-hmm.
right? Is there issues with resin in like
It
composites?
depends
and stuff
on the
like that?
person, but I think our bonding agents for sure have BPA.
Sure.
I mean, there's like 1 or 2 companies that have it, but I don't know how good it is. So we have this thin layer for sure of BPA, and then almost all of the resins out there, like the byproducts can have it. So even if it's not like one of the main components, like the byproducts down the line. So I've found that Admira Fusion is just an amazing product that's like all ceramic, but still gives you all the benefits of using a resin. It's really strong, holds up for a long time. I've seen like 10-year recalls with it in really good shape. But you just have to really like talk to the patient and like think about biocompatibility for them.
Sure.
So it's more precision based, because some people may be really sensitive to certain things and others may not. So you can do like the biocomp test or one of those, and they'll give you a list of the composites that do work and that don't work, or at least would they have antibodies to.
Sure. Okay,
Yeah.
cool.